Okay, time for plantar fascia.
I'm going to show you how to scan the plantar fascia and the Achilles tendon. So it's super important that your patient is prone with the ankle hanging off the end of the table, the foot hanging off the end of the exam table. Your landmark is going to be the inferior calcaneus, the plantar aspect of the calcaneus for this plantar fascia. The orientation of the probe is long on the foot, and the movements are going to be slight movements medially and laterally, and then also some angulations to make sure you get a very, very bright calcaneus. The area of interest is going to be the 3, 4, or 5 millimeters of tissue sitting just superficial to the calcaneus. So that's how you scan plantar fascia.
Okay, time to draw it. All right, bone. Well, we know this is bone, so that's what this is here. So here's your calcaneus. Note that a lot of people have this sort of shelf of a calcaneus, sort of a bit like that. Let's clear that away and do it one more time. A lot of people have a bit of a shelf. A lot of people have more of a shelf, and it's not really a spur. Cartilage, well, there's no cartilage in view. Fluid, bursa, joint, ligament, none of that. Tendon, well, I suppose we can call, why don't we call the plantar fascia a ligament? Because it kind of connects one bone to another bone. So in that, it connects the calcaneus to the 5th metatarsal, to the rest of the metatarsal heads, and then also over here proximally like so. So we'll call this a ligament. And you can kind of sense that it comes all the way around like this. Yeah, quite a broad area. All right, there we are. And muscle, there's quite a lot of muscle in this view actually. So there it is. Now which muscle it is depends if you're headed in this direction, or the middle. But anyways, let's clear that away. Let's do it one more time. So here's bone. No cartilage, no fluid, no bursa, no joint. Ligament, we're going to call the plantar fascia or plantar aponeurosis a ligament because it connects bone to bone. So that's that there. And muscle, we have a bunch of muscle down here. Now, it's worthwhile mentioning here that all this up here, we're going to co-opt this color in for fat because this is all the heel fat pad. Why? Well, because this is all the heel fat pad, right? Just up above it is the heel fat pad. Okay, so let's clear that away and let's see what it looks like in a live patient.
Going to show you how to scan and inject the plantar fascia. Our patient positioning in our group is preferably with a patient prone, however different practitioners may have different setups. The landmark is going to be the bottom of the calcaneus, and the movement of the probe is going to be towards the toes. You can see the orientation of the probe is long on the foot. The yellow arrow is now centered inside the plantar fascia. If I were going to do the injection, I would simply spin the probe like this. Well, the yellow arrow is still within the center of the plantar fascia. My needle angle of entry is from medial to lateral, having placed enough anesthetic in the skin to make it less painful for the patient. There is some disagreement between doctors about where to place cortisone, for example. Many radiologists advocate placing it directly in the center of the plantar fascia, while some prefer to place it superficial to the plantar fascia. Some may argue that if you place it superficial to the plantar fascia, you may get fat atrophy or fat lipodystrophy. So therefore, some prefer to place it deep to the plantar fascia. In that case, you would simply slide towards the toes. We now see the deepest aspect of the plantar fascia here, and you can place it, the cortisone, in the interface between the plantar fascia and the underlying foot musculature. So that's how I would scan and inject the plantar fascia.
Excellent. Now it's time to move on to the quiz. Hey, congrats on finishing that section. Can I show you inside one of our live courses? Let's go.
I certainly can say that Frank's courses are very well structured, very well taught, very practical.
Just even being able to use ultrasound in like the top 25 conditions are the ones that we see in clinic.
There's a huge community and a huge well of knowledge when you join one of the courses and you have access to all of these people who have seen a lot more than you have, and there's no guesswork. You leave feeling very confident with what you need to do to be successful for your patients and then in your practice.
You want to be able to do basic hip injections, shoulder injections, elbow injections, and I think Frank Johnson set up a very good protocol and a very good syllabus to be able to get the top type of procedures you're going to be doing in clinic and make sure you understand those well before moving on to the next step.
My revenue went up almost instantly. There's always now just more opportunity to reinvest into my clinic, reinvest into the things that I like, and I've been very satisfied.